So thank you. Today's topic will be the pain perception and management during the usage of DEBRICHEM. And I will first give you a short overview about biofilms, about what they do to wounds, and about how DEBRICHEM works. So biofilms are by definition communities of microorganisms attached to a surface or to each other and encapsulated in a matrix of extracellular polymeric substance. And they contribute to over 80% of surgical site infections. They are both found in acute and in chronic wounds, and they lead to a local but unfortunately ineffective immune response that leads to delayed wound healing due to a chronic inflammation. And the therapeutic challenges that they are usually, as they are protected by this polymeric substance, they're tolerant or resistant to antibiotics, and so unfortunately antibiotics can only control the spread of the bacteria, so they can control the sepsis maybe, but they can't treat the biofilm itself. And another recommendation is sharp debridement to reduce the microbial load, but again, it's not sufficient on its own. So wounds and biofilms, so what's the weak spot? So we can't attack the biofilm with antibiotics, we can't attack it with sharp debridement, and obviously this extracellular polymeric substance is protecting the bacteria from a proper immune response or from a proper immune attack. So how do we spot the weak spot in the biofilm? So mature biofilms, they're mainly composed of fluid by over 95%. And in vitro studies have shown that they contain water channels that basically serve as a circulatory system. So they transport, they serve as a transport route for nutrients, for oxygen, and for waste products. So it's a kind of metabolic system which the bacteria depend on. And how do we tackle that weak spot? By using desiccation, just like DEBRICHEM does it. So it basically dries up the whole metabolic supply, which the bacteria depends on, by binding water molecules. And so to introduce DEBRICHEM one more time, it's an innovative desiccating hygroscopic agent for chemical debridement, which dries up the biofilm. It's applied for 60 seconds to the wound and 1 centimeter onto the wound, peri-wound skin. And how it works actually, it contains methane sulfonic acid, which leads to rapid desiccation. So it uses up the water within the biofilm, and on contact with water, it leads to an exothermic reaction, and it becomes pretty hot, so it releases a lot of energy, 1,500 kilojoule per mole, and this amount of energy, it actually destroys the biochemical bonds in the infected and devitalized tissues. So in the following days, the tissues then get desiccated and denatured. So just to show you an example, so that's before DEBRICHEM, that's one of the wounds, and as typical for biofilm, you don't see it immediately. So and it's pretty hard to diagnose it too. But one criterion for biofilm is you have to think about it if nothing else helps. So if you have a wound that just doesn't heal, you have to think about biofilm. And that's after DEBRICHEM application. So you see immediately a dry film on the wound, which looks a little bit darker than before. And then in the following days, it just coagulates together. So that's what you see in the middle of the wound. That's actually denatured tissue, which leaves behind, hopefully, a clean granulation tissue in the following days, and then epithelialization can occur after weeks. And what we did actually, so we know that DEBRICHEM works in wounds, so that's nothing new. We have several case reports that showed that it can be successfully used in hard-to-heal wounds. So it's a potential alternative or additive to sharp or surgical debridement, but the challenging part is the patients report of a strong burning pain sensation. As you can imagine, you apply an acid, it becomes pretty hot, it dries up the whole ground of the wound, so that's painful. And the aim of this study was to find an optimal pain management to control and to lower the pain to an acceptable level, at least to a level where you can compare it with sharp debridement. because the patients, they usually know the sensation, they know the pain, so it would be acceptable if we can at least have a non-inferiority result. And so we let the patients evaluate the individual pain perception and the management options with different local anesthetics. And here on the right you see a VAS scale, a visual analog scale from 0 to 10. 0 means no pain at all, and 10 is the strongest imaginable pain. And the aims are, so we have, it's an ongoing study, we have about 14 patients, our aim are 30 patients in total. And so the aim is a subjective evaluation of the pain perception during and after DEBRICHEM, compared with sharp debridement, and a comparison of different local anesthetics. So we have two groups so far. We have an EWMA group with lidocaine, it's a lidocaine cream, and a tumescence anesthesia with Xylanest 1% solution. And we compared both. And to stay close to the clinical setting, we allowed the patients to receive their oral pain medication and also their exit acute oral pain medication as needed during wound dressing changes. And to get to the methods, so we applied the local anesthetics, either amlacrene or Xylanest solution for 30 minutes, and then applied DEBRICHEM to the wound and asked for pain ratings during DEBRICHEM application and afterwards. And we also asked for pain ratings for the sharp debridement that the patients usually get. And we further asked for the baseline pain, for general dressing change pain, and after DEBRICHEM application 15 minutes later and 3 days later for further pain ratings. We excluded patients with polyneuropathy or neuropathy or diabetic foot syndrome to get a clear evaluation of the pain sensation. So, and these are the preliminary results. So we have 14 patients so far. We have 8 patients in the EWMA group and 6 patients in the tumescent group. And just to keep it short, you see we have no significant difference. So if you apply local anesthetics, EMLA on the left, and you apply DEBRICHEM, and then you compare to sharp debridement, you have no difference. And also that also accounts for tumescence. And also if you compare EMLA and tumescent, then you have no significant difference, which means we could pool the data to our 14 patients on the left who received either EMLA or Xylanest and received DEBRICHEM, and we compared it to the pain ratings of sharp debridement, and you also see no significant difference. And on the right you just have an overview of the 3 groups, of the 2 groups compared to sharp debridement. So actually that's a nice result. So we had a clear question, we have a clear result. So to come to the conclusions, pain is indeed well manageable. During DEBRICHEM treatment, you can combine ready-to-use local anesthetics, EMLA, Xylanest, which you usually have in the clinic. And in addition, you can also let the patient have the oral pain medication. And under local anesthetics, you have no significant difference to sharp debridement in pain perception. So DEBRICHEM leads to no stronger or superior pain if you compare it to sharp debridement. So we also achieved our non-inferiority aim, actually. And further outlook would be to complete our case series with further local anesthetics, so with a 3rd group with anesthetic gel. We would like to improve our pain management with higher concentrations, for example, for the tumescent anesthesia, and we would like to investigate for further pain aspects, for example, the afterburn effect. But just to sum it up, we have no significant difference between DEBRICHEM treatment, between the pain perception during the DEBRICHEM treatment and sharp debridement, and so we achieved a first aim in this study. And I thank you for your attention.